Okay, chapter 44 and 45, chronic disorders of neurological function. So in this chapter, we'll talk about motor neuron damage, the requirements of the motor system, look at some disorders of skeletal muscles, and then look at alterations of neuromuscular function as well as problems in the neuromuscular junction. And then we'll end with myasthenia gravis, neuropathies, and Guillain-Barré syndrome. So classifications of muscles and mechanisms controlling coordinated movement. So we need to know our muscle types. So we have our extensors and flexors. So our extensors are muscles that increase the angle of a joint. Think of your triceps. And then our flexors are muscles that decrease the angle of a joint. Think of your biceps. Agonists promote movement. So they're going to work together. Antagonists oppose movement. So your biceps and your triceps would be antagonistic muscles because one flexes and one extends. And then synergists are going to assist the agonist muscles by helping to stabilize the joint or contributing to additional force for the movement. So just some terminology. So what are the requirements of the motor system? So obviously we need our primary motor cortex, obviously. And then we need to send that information from the brain down to the spinal cord, out to our muscles to cause the muscles to move. So the neurons are pretty important. We have our upper motor neurons and our lower motor neurons. Our upper motor neurons, their cell bodies are going to be in the brain, and they're going to send their axons down the spinal cord. And they will directly or indirectly innervate the lower motor neurons of our contracting muscles. Our lower motor neurons, their cell bodies are in the spinal cord, and then they are going to send their axons out the periphery into or directly to innervate our skeletal muscles. So obviously these neurons are important in getting the message from our brain to our muscles so that we can achieve voluntary movement. So what happens if we damage these neurons? And some of the consequences will be similar, but depending on whether we're talking about our upper or our lower motor neurons, the consequences might be slightly different. For example, with upper motor neuron damage, again, these are the neurons in the brain, obviously you're going to lose voluntary motion because you're not going to even start any signals going down the spinal cord to our muscles. So you'll have weakness and loss of voluntary motion. However, our spinal reflexes will still remain intact. And so spinal reflexes, remember, is when sensory neurons from the periphery bring the sensory information into the spinal cord, and then those neurons will directly or through an inner neuron innervate the motor neurons, the lower motor neurons in the spinal cord, and then cause movement. So basically in a spinal reflex, just the spinal cord is involved, the brain is not. So even if you damage the upper motor neurons, these spinal reflexes will remain. So if you go to the doctors and they hit your patellar tendon and your leg shoots up, that would still remain even if you had upper motor neuron damage. However, it might be a little bit different. So you'll have increased muscle tone, you'll have hyperreflexia, so you might have an over-responsive reflex, and you might have some spasticity. If you damage the lower motor neurons, then you're damaging the neurons that directly innervate our muscles. And so you will still lose voluntary motion, you'll have weakness. But if you have, for example, irritated neurons, it can lead to spontaneous muscle contractions or fasciculations or twitching. And then if you have complete death of the motor neuron, then it will lead to spinal reflexes that are also lost. You'll have flaccid paralysis and denervation atrophy of our muscles. So denervation atrophy means that our muscles are going to atrophy a little bit more than just decreased use atrophy. And that's because, again, the neuron is no longer there. So again, lower motor neuron, you will lose the spinal reflexes. So what are some of the other requirements for the motor system? So obviously the upper and lower motor neurons are important, but other requirements include our sensory neurons. Now, sensory feedback is really important. It's going to continuously relay information to our cerebellum, our basal ganglia, our sensory cortex to essentially help our brain decide how we are going to move. For example, let's think about if you go to the dentist and they put Novocaine in your mouth so that your mouth is numb, and your entire mouth gets numb, your lips get numb, and then they tell you to gargle. No matter how much you try, you still kind of drool that water as you're gargling, and that's because you can't really feel the water, and so you don't know how to move your mouth to kind of keep that water in. So that sensory information is really important in how we execute our motor output. So sensory information, very important. We also need to plan our movement and then obviously execute it. So the planning of the movement occurs in the premotor cortex. The execution of the movement happens in the primary motor cortex. We also have our pyramidal motor system and our extrapyramidal motor system. So the pyramidal motor system originates in our motor cortex, and it provides control of our delicate muscle movements. The extrapyramidal originates in the basal ganglia, and it provides more of the background, crude supportive movements or support that you need for the movement to occur appropriately. So what would you call a defect that causes weakness in both arms? So since it's two arms, we are going to use the prefix di, and it's called diparesis. So think of paralysis, but in two arms, diparesis. What about if it's weakness in the right arm and the right leg? So it's just the right side of the body, so it is one hemisphere. So this is known as hemiparesis. If you have an inability to move one leg, for the word one, we have the prefix mono, so this is monoplegia. And then if you have an inability to move both legs, that would be paraplegia. And if you can't move any of your arms, that would be quadriplegia for 4. So let's take a look at our motor neuron. So here we have our lower motor neuron, and just neurons in general. We have the dendrites receiving information. Here's our cell body, our myelinated axon here, and this guy is our somatic motor neuron, so it's innervating a skeletal muscle fiber. This neuron also is myelinated because this is in the peripheral nervous system. It is myelinated by Schwann cells. If it was in the central nervous system, it would be your oligodendrocytes. And that myelin helps increase conduction velocity, so the action potentials travel very quickly via saltatory conduction. I want to just define motor unit very quickly. A motor unit is one motor neuron and all of the fibers that it innervates. And it's called a unit because when this neuron fires an action potential, at the terminal, it will always go down all 5 terminals, 1, 2, 3, 4, 5, which means all 5 fibers that this neuron is innervating will be stimulated together. And so the 5 fibers and this one neuron always act together. Hence, they are known as a unit or a motor unit in this case. So what could go wrong with the motor unit? So here we have a blowup of our neuromuscular junction right there. So here's our somatic motor neuron terminal. Here's the muscle, and the muscle where the neuromuscular junction takes place is known as the motor end plate. And we have these invaginations, and we have clusters of our nicotinic acetylcholine receptors. So things that can go wrong could be we can have a lower motor neuron lesion or infection, or we have just peripheral nerve injury. We can have issues in the neuromuscular junction itself, or there could be an issue in the muscle. So we can have muscle atrophy or muscle dystrophy. Now, what about if we take a look at the synapse? What's happening in a synapse? So here I have a postsynaptic neuron, but this could be a muscle as well. Okay, so these steps are similar. So when an action potential goes down to the terminal, voltage-gated calcium channels open, calcium will enter, and it'll trigger exocytosis of these synaptic vesicles that carry the neurotransmitter. Now, if this were a somatic motor neuron, and if this were a muscle, obviously it's not in the picture, but if it were, the neurotransmitter that was released or that would be released would be acetylcholine. So that's happening in stage 1, the release of the neurotransmitter, exocytosis. In stage 2, that neurotransmitter is binding to the receptors on the postsynaptic cell. And then in stage 3, after the binding has happened and the stimuli has happened, you now need to get rid of the neurotransmitter. And there are 3 ways. The cell that released it can take it up, or enzymes can break it down, or 3C, it can diffuse away into the blood or just away from the area. And so that's what's happening in each of the stages. What would happen if you blocked each of the stages? So if you block stage 1, again, we're going to assume this is a muscle. If we block stage 1, then you're not releasing the neurotransmitter, and so you wouldn't be able to move. You wouldn't be able to contract your muscles. If you block stage 2, you're blocking the acetylcholine from binding to the receptor. So you're letting it release, but you're still not letting it bind. So again, you still won't be able to move. But if you block stage 3, remember stage 3 is when you're getting rid of the neurotransmitter. In that instance, you'll have your contractions that are too big. So your contractions will last longer and be bigger than they should be because you're not removing the neurotransmitter like you normally should. So how is the spinal cord organized? So the spinal cord is highly organized. Here we have our dorsal and our ventral regions of our spinal cord. In the dorsal root, we have our afferent or our sensory neurons that come in. In the ventral root, we have our motor neurons or our efferent fibers that go out. And the spinal nerve will contain both our afferent and our efferents. As the spinal nerve, again, gets closer to the spinal cord, we will split into our dorsal and our ventral roots. So again, our sensory neurons coming in through our afferent fibers, our motor neurons going out through our efferent fibers. So a woman developed a polyneuropathy. So that means poly of her neurons were damaged. So her spinal nerves were damaged. And she lost the ability to tell where her body was positioned. She has to look every time she takes a step. So she can still move. She has voluntary movement, but she can't tell where her body is. She has to look every time. So what parts of her spinal nerves were damaged? Were they her dorsal or her ventral? Were they her sensory neurons or her motor neurons? So she can walk, but she has to look every time with her eyes because she can't tell by touching with her feet. So it would be her dorsal or her sensory nerves that were impacted. So knowing your anatomy and how everything is organized, it really helps figure out what areas were damaged because you know where certain neurons are located. Now, disorders of skeletal muscle groups. We have muscle atrophy and dystrophy. And these are terms I've used before. And we know the word atrophy. That just means you're going to decrease in cell size. In this case, it's muscular atrophy. So your muscles will decrease in size. And this happens when you make less contractile proteins, less actin and myosin. And you would do that because you're not using your muscles. So decreased use would lead to muscle atrophy. And if you've ever had your leg, for instance, in a cast for a period of time, you know when the cast comes off, your muscles have gotten smaller because you haven't used them. Then we have muscular dystrophy. Now, muscular dystrophy is a genetic disorder, and it causes progressive deterioration of your skeletal muscles. And it's because of some of the proteins in the sarcolemma are altered. And so you actually get a mix of muscular hypertrophy, atrophy, and necrosis. Now, how do you get a mix of all of these? Well, think about it this way. If some of your muscle fibers are more impacted than others, then when you contract, the ones that can still function normally will start to take over and be used more, so they will start to hypertrophy, while the other muscles that have greater disorder will start to atrophy. And then again, because this is a genetic disorder that is progressive, muscle necrosis can also occur as well. So alterations of neuromuscular function. Let's talk about what happens at the neuromuscular junction. So drugs and other agents can alter neuromuscular function by changing the release, the inactivation, or the receptor binding of our acetylcholine. So one example is Curare or Curare. So this acts on the post-junctional membrane of the motor end plate, and it prevents the depolarizing effect of the neurotransmitter. Essentially, it blocks your acetylcholine receptors. So when your motor neuron releases acetylcholine, the receptors that they're supposed to bind to, the nicotinic cholinergic receptors on the motor end plate they're supposed to bind to, they are being blocked by Curare. And so it's used, and as a result, obviously, that means it causes your muscles to not contract. You have paralysis. So it's used a lot of the times in surgical procedures where you don't want the patient to move because you're doing delicate surgery. Then we have Clostridium botulinum. This blocks acetylcholine release. So what this does is acetylcholine, when it's in those synaptic vesicles at the terminal, waiting for the calcium to come in to tell it to exocytose, it prevents those vesicles from docking onto the membrane. And so if the vesicles can't dock or attach to the membrane, then it can't attach and open up to release the acetylcholine. So basically, you can't release acetylcholine. And as a result, you will also cause paralysis. So these problems in the neuromuscular junction, like we said, can be decreased acetylcholine release with botulism, which is caused by the Clostridium botulinum, and you might have heard of a Botox. So that's essentially what Botox does. Then we have decreased acetylcholine effect on the muscle. So here you're letting the acetylcholine get released, but it's not causing an impact on the muscle because in Curare, you are blocking the receptors. In myasthenia gravis, you are essentially destroying the receptors, and we'll talk about that. And then we have decreased acetylcholine esterase activity. So acetylcholine esterase is an enzyme that breaks down acetylcholine. So the breaking down of your acetylcholine or the neurotransmitter by enzymes was another way to get rid of neurotransmitters after they're released. And the enzyme that breaks down acetylcholine is acetylcholine esterase. So if you decrease its activity, that means you're going to have more acetylcholine in the synaptic cleft, and so you're going to have a stronger effect on the muscle. And organophosphates will do that. So let's talk about myasthenia gravis. So it is a disorder of transmission at the neuromuscular junction, and it's an autoimmune disease where you have destruction of your acetylcholine receptors. So if you destroy your acetylcholine receptors at the motor end plate, then your muscles won't be able to contract. And it's associated with a thymus tumor or hyperplasia of the thymus. So it's not fully understood, but we know that the thymus is involved in immune cell maturation, especially of those T cells. So there might be some incorrect directions given. And then because your muscles can't contract, you're going to get weakness. But the weakness develops from proximal to distal portions of the body. So the muscles that are closer to your trunk get impacted first, and then think of your fingertips and your toes get impacted last. And if it impacts your respiratory muscles, like your diaphragm, your intercostals, then it leads to myasthenia crisis since your respiratory system is compromised. Now, what about peripheral nerve injuries and regeneration? So our peripheral nerves are pretty good at regenerating, but it depends on a few things like how, are you still attached to the cell body? Is the cell body intact? So we can have injuries where the cell body is damaged. These won't really be able to regenerate. You can have damage to the axons, and these will be able to regenerate if we're talking about the part of the neuron that's still attached to the cell body. We can also have just damage to the myelin sheath, so that would be a demyelination damage, and we see that with multiple sclerosis. And then we can have damage to the axons, which I already mentioned over here, and that can happen as a result of different degenerative conditions. And then again, what determines how well you regenerate? It's your cell body. So how close are you to the cell body? Again, are you still part of the neuron that's still attached to the cell body? So peripheral neuropathies are any primary disorder of peripheral nerves. It can result in muscle weakness. It can occur with or without atrophy or sensory changes, and it can involve a single nerve. That would be a mononeuropathy, and an example of that would be carpal tunnel syndrome. And then it can involve multiple nerves. That would be polyneuropathy, and an example of that is Guillain-Barré syndrome. So mononeuropathies first, these are caused by, again, localized conditions like a trauma, a compression, or infection, and it affects a single nerve or a single plexus of nerves. And so things like a fractured bone that can lacerate a nerve, or an excessively tight tourniquet that can injure nerves directly or through ischemic injury, or even an infection can lead to mononeuropathies. Polyneuropathies involves demyelination or axonal degeneration of many nerves. So many nerves are involved. So it can lead to sensory, motor, or a mix of those two deficits. And typically, unlike myasthenia gravis, where the weakness happened from proximal to distal, polyneuropathies tend to happen in the longest axons first. So the symptoms begin distal and then go proximal. So an example of a polyneuropathy is Guillain-Barré syndrome, where you're going to get weakness where it starts distal to proximal. And this is also an immune mechanism. We'll talk about that next a little bit more. But other causes of polyneuropathies include toxic agents, so arsenic poisoning, lead poisoning, alcohol poisoning. So these toxic agents that get into your systemic circulation are going to then get sent everywhere to your body, and so many nerves are going to be impacted. And then metabolic diseases like diabetes mellitus or uremia. Again, these are in our blood, and so they're going to go to multiple nerves and impact them. So a little bit more about Guillain-Barré. So this is an uncommon inflammatory disorder where your body's immune cells starts to attack your nerves. And so it's going to cause severe weakness and numbing. And again, it tends to start from distal to proximal. So the weakness will start distal to proximal, and the whole body can become paralyzed, and there's no cure. So the treatments are really designed to try to ease symptoms and reduce the duration, but most people tend to recover completely, even those with the most severe Guillain-Barré syndrome cases. So we will end with a few questions. So first is, lead toxicity would result in which of the following? So again, think of lead, it's systemic, it's going to go everywhere, and so many nerves are going to be impacted. So it's a polyneuropathy. So now let's take a look at synaptic transmission and therapies based on it. So acetylcholine, we know, is the major neurotransmitter involved in stimulating our skeletal muscles. In myasthenia gravis, we know that acetylcholine receptors are destroyed by the immune cells, and so the client becomes progressively weaker. Would you expect better results if the client were given an acetylcholine agonist or an acetylcholine antagonist? So essentially, this is asking if you know the difference between an agonist and an antagonist. And obviously, if you're destroying acetylcholine receptors, taking away more acetylcholine would not be helpful. Giving more would be. So an agonist would help. So yes, you're getting rid of receptors, but by giving an acetylcholine agonist, what you're trying to do is you're trying to activate the few receptors that are still available. If you give an antagonist, that would even further decrease the effect of acetylcholine, so that would not be the wise choice. What about an acetylcholine inhibitor or an acetylcholine esterase inhibitor? And remember, acetylcholine esterase is the enzyme that breaks down acetylcholine. So if we inhibit that guy, then we're going to break down less acetylcholine, so more acetylcholine will be around. So we want to give an acetylcholine esterase inhibitor. And interesting fact, Raid, that insect killer that you spray, is an example of a drug that does this. It's an acetylcholine esterase inhibitor, and it sends your insect into a seizure. Oh, and that's it. Thank you.